Hello, and welcome back to the Daily Dose of Medical Ethics with Dr. Albina. Today, we will be learning about the ethics in communication in Do Not Resuscitate orders in an article written by physicians Tom Tomlinson and Howard Brody. What exactly is a DNR? DNR stands for the Do Not Resuscitate and is a medical order written by a doctor or physician only after they have spoken to the patient and or his or her family members. Ways a patient can be resuscitated is by mouth-to-mouth, electric shock to the heart, breathing tubes to open the airway, and certain medicines. A DNR instructs that CPR or ACLS is not to be performed if the patient's breathing or heart stops. An important thing to know is that DNRs do not provide instructions for any other treatments, such as pain medications. If prior to being unconscious, the patient has requested a DNR to be written, family members are in no way, shape, or form allowed to dispute the order. Since the patient's full autonomy was present prior to the incident, their health decision cannot be overridden by their family members. Now let's take a look at what roles different factors play when making a decision to request a DNR order. The first category considers the patient's personal factors. A patient can be unsatisfied with their current quality of life or health status. They might be in a situation where they lose their independence and have to rely on help with everything, causing them to lose all their motivation to live. Another large factor that comes into play is having a poor anticipated quality of life or health status for the future. Patients who are ill oftentimes look ahead and picture what their life would be like if they continued to live with their illness. If they see themselves being isolated from the world, they would rather not live anymore. The last personal factor that determines a patient's decision to requesting a DNR order is pain associated with resuscitation. If a patient is in severe pain and has been told they only have a few more months to live, they would rather not be resuscitated, only to have to continue to live in the pain. Moving on to the second category of motives for a DNR order are relational factors. Patients can have a desire to avoid being an emotional burden on family members, wanting to prevent causing them hardship. Another factor could be the patient's concern about being a burden to healthcare workers, feeling that it is unfair to the caretakers to have to tend to their needs. Last but not least are the philosophical factors. Many patients tend to feel discomfort or disagree with the idea of life support. They would rather die when it's their time to go than to be kept alive artificially. Many also obtain an inevitability of death, believing that if they're dying, there is nothing that can change the outcome. While reading the article by Tom Tomlinson and Howard Brody, they argued the three different rationales for DNRs. The first rationale was that CPR would be futile and thus would offer no medical benefit. They argued that a DNR order is justified because resuscitation would almost certainly not be successful and would be of no benefit to the patient. The second rationale was that there would be an unacceptable quality of life after CPR. They argued that the life that would remain might be of little or no benefit to the patient. If there were benefits, they would be far outweighed by burdens. A crucial feature they made sure to point out was that the resuscitation efforts, or even both, threaten a change in the patient's quality of life from one that is at least minimally acceptable to one that is completely unacceptable. Lastly, the third rationale discusses how prior to the CPR, there is an unacceptable quality of life. A crucial feature the authors made sure to urge is that the judgment of this rationale concerns the patient's current quality of life, not merely the quality of life after an arrest. These two authors also take into consideration two different contrasts among the three rationales: the relevance of the patient's values and the generalizability of other possible treatments. First, they discuss the relevance of the patient or family's values to the justification for the DNR order. Since there is a possibility that the patient and physician may have opposing values, the patient obtains both a legal and moral right to accept or refuse treatment solely due to their values. In conclusion, the justification of a DNR order on the bias of any quality of life rationales requires that the decision be based on values presented by the individual patient themselves. The second considered contrast discusses the generalizations to other treatments that may or may not be provided. The patient's specificity in the event of an arrest and subsequent resuscitation, and the generalizations they have allowed about the appropriateness of treatment options besides CPR must be crystal clear, for resuscitation implies absolutely nothing about the consequences of other life-threatening events and their related treatments. Philosophers Tomlinson and Brody also discuss some of the important aims physicians should consider when communicating with their patients. Communication with the patient or their family should aim at securing and understanding the decision the physician has already made in a situation where there is an absence of medical benefits. This decision is based solely on medical expertise, and the discussion should inform the patients and/or family members of the medical realities and attempt to persuade them of the reasonableness of the DNR order but at the same time not to completely disregard the patient's wishes and violate their autonomy if resuscitation is insisted. As opposed to this situation, when the quality of life rationale is involved, the discussions with patients and or their family members has totally different objectives. In this case, the physician must not only have the patient or family's understanding of a DNR, but also their permission or consent. It is unacceptable for a physician to persuade or force the patient or family to request that a DNR order be written. Unfortunately, a DNR order can be a recipe for a huge misunderstanding, dissension, and anger amongst the professional staff. Potential issues arise due to the uncertainty about which of the three rationales that is being applied in different cases. There can be a disagreement over what constitutes a cardiac arrest. Without knowing the rationale, it is merely impossible to understand or interpret a DNR. Studies show that almost half of DNR orders have no written explanation or justification to serve as a guide for physicians and staff. Physicians who write the DNR orders very often indirectly intend the order to include other interventions besides CPR, such as antibiotics, blood transfusions, and antiarrhythmic drugs, but fail to specify this. Here is an example of a DNR case I found about a 39-year-old man with chronic lung disease who has been admitted to the hospital for shortness of breath. He was treated, but his health conditions failed to improve, and physicians recommended a ventilator to treat him temporarily. The patient has refused to use the ventilator. He does not have a living will, nor does he have a pre-hospital DNR, but requests that a DNR be entered by his physician. After understanding all the risks and benefits of the ventilator treatment, the patient still decides to refuse treatment and requests a DNR. Although the patient is refusing this life-saving treatment, he has thoughtfully considered and rejected the ventilator multiple times when discussing his wishes with his doctor and wife. The action the physician should take is not to force the ventilator onto the patient and enter a DNR as requested. This is an ethical decision because the patient has his full autonomy present and also has the moral right to make his own medical decision to refuse this treatment. At the end of this presentation is my works cited sources and also a little thank you to the wonderful Professor Fries for teaching us all so much knowledgeable information in the field of ethics in healthcare. I hope you enjoyed today's episode of the Daily Dose of Medical Ethics with Dr. Alvina. Thanks for watching!